Good morning, all. My name is Siddharth. I am from Vijay Medical College, and today's my topic is brachial plexus block. Different approaches. That is in relation with ultrasound. So in this topic, I will discuss these approaches. That is interscalene, superior trunk block, supraclavicular, costoclavicular, infraclavicular, and axillary approach. So let's start with first one, that is interscalene approach. As we all know that it is root level block, and C5, C6 and C7 root are blocked. C8 and T1 they are spare. Scanning is usually performed in supine position, head elevated and turned to the opposite side, or in lateral position. In both positions, operator lies on the same side and machine on the opposite side. This is for aboveclavical blocks. Usual machine setting, in that I utilize high frequency linear probe in nerve region in resolution mode, keeping that up to 2 to 4 centimeter. And the needle that I use is 2.5 to 5 centimeter needle in plane approach from lateral to medial, and dose that I use for interscalene block is 15 to 20 ml of local anesthetic. Scanning is usually performed in two way. One is cricoid to scalene. First we have to scan the cricoid, and then we have to go to the interscalene groove, or in like traceback technique, in that we have to go first supraclavicular and then we have to reach to the interscalene. I personally recommend this technique because it gives you a very good idea about brachial plexus anatomy. When we put probe on interscalene groove, the plexus appears hypoechoic nodule covered with hyperechoic reef in between the anterior scalene muscles and middle scalene muscles. See, sorry. Okay. So on the anterior scalene muscle, we will find the phrenic nerve, and just above to the anterior scalene, we will find the tapering sternocleidomastoid muscles. Here the vertebral vessels are visible because it is at the level of C7, and here we will find traffic signal sign. Actually it is misnomer C5, C6, C7, but actually the numbers are like C5, C6 and C6. It's not C7 because here the roots are splitted, specifically C6 and C7. The main peculiarity is that C5 root is smaller in size, C6 is splitted proximally, C7 is also splitted proximally. So the number what we count 5, 6, 7 is actually 5, 6, 6, 7, 7, just like that. And these number can be identified by the presence of tubercle on transverse process of that particular vertebrae. Like in C7, there is absence of anterior tubercle, so we will find the vertebral vessels. So that root is actually C6. Sorry. This is C7 as because of absence of anterior tubercle over here. Here two tubercle are seen, so this is C6. Subsequently, when we go cephalad from C7 to C6, and when we go cephalad, C5 is also having two tubercle. So this is a way by how we can identify the number of roots. So the scanning technique, in that first you have to go with cricoid to interscalene groove. See, the plexus are visible and two scalene muscles in between. See, this is C7, vertebral vessels are seen. This is C6, two tubercle. Here C5, two tubercle. Let's go caudally, C5. This is C6. And this is C7. And we find vertebral vessels over here because of the absence of anterior tubercle over here. So this is the plane from where we will insert the needle from lateral to medial and will reach to these plexus. Again, second technique in that traceback, in that first we will go with supraclavicular region and then we will reach to the interscalene. See, this is C7, dorsoscapular artery, C6, splitted C6, and C5. Again, we go caudally, C5, C6, dorsal scapular artery, and C7. So this is a method how we can scan interscalene approach. Let's see some block. In that we can say needle will come from lateral to medial, piercing the skin and middle scalene and reach to the targeting C5 and C6 root, and I will inject volume in between the sheath and plexus, that is 15 to 20 ml of local anesthetic. The main idea is that drug should be lies in between the sheath and root. Either single injection or multiple injection, it's all depend on drug distribution. Let's see some clinical pictures. In that, use ergonomic, because you never know, you require a nerve block for shoulder pain or back pain. Use pillow or ring to make some space for needling. Make needle tip visualize all the time, and use color Doppler to identify the dorsal scapular artery and transverse cervical artery. This is the normal artery which is present over there, and you have to avoid this artery while doing your block. See, in one of my video you will find dorsal scapular artery is over here. Can you see? This is big one in between the, which is crossing the plexus over here. This is middle scalene, this is anterior scalene, and this is the plexus. C5, C6 splitted, and C7. This is dorsal scapular artery over here. So vessels are normally there, you have to avoid. Second thing, in that you will find the superficial cervical artery just on the top of the plexus, just below to the superficial cervical plexus, somewhere over here. Here is a transverse cervical artery. So vessels are normally there, you have to avoid them. One more thing is that we have already talked that C6 and C7, they are splitted proximally. So the safer injection which I recommend is C5, in between C5 and C6 and C6, because you never know, you are entering in between the C6 and C6 again, because C6 is splitted over here. So here what I have told is that the traffic signal sign is not actually 5, 6, 7, it is 5, 6 and 6. So it can cause intraneural injection if you try to be in between these two roots. One more thing is that C5 root may be present in anterior scalene muscles. See, in one of my video you will find this is anterior scalene, the neural element, it will mix with C6 and they form the superior trunk. When we go from interscalene to the supraclavicular region, see this is C5 which meets with this C6 and they form superior trunk over here. So this is one of the abnormality, like the C5 root may be present in anterior scalene, so that can be a reason for your block failure if you can't scan properly. So I suggest you to use TRASPEC technique always when you go for any type of brachial plexus block. Here most of the time you require supraclavicular nerve blocks along with interscalene approach, that are the branches from superficial cervical plexus, and the hemidiaphragmatic palsy is almost 100% with interscalene. So phrenic palsy is a consequence of interscalene block. Okay, if your block is working, that means phrenic is paralyzed. Okay, so this is 100% cases in a reasonable volume, that is 15 to 20 ml. If you use less volume, that might chance, but I think in my practice I have seen almost all the cases I found that this is 100% pulse. So for that reason, our expert have found one superior trunk block which gives where the union of C5 and C6 root. At that point we inject the drug, that the dose that we require is a little bit less, that is 15 ml. They have started with 15 ml and reduce up to 5 ml, and here we will find this phrenic palsy chances are reasonably up to 5%. This is based on some studies. And the local anesthetic, I have talked already 5 to 15 ml of local anesthesia. Let's see some screening in that. Again, the C5 and C6 they form, and they form the superior trunk, and here the 3 branches, that is SPA, that is suprascapular nerve, posterior division and anterior division. See, I am scanning dress back. See here 3 roots over here, and they form the superior trunk. Okay, C5, C6 meets, they form superior trunk. When we go caudally, we will find the suprascapular nerves, posterior division and anterior division. See, the block is almost same, but at the level of, the technique is almost same, but at the level of superior trunk, and drug is distributed in between the sheath and superior trunk over here. And see, all the superior trunk has been covered with local anesthetic. This is subclavian artery which is giving branch over here, and this is middle trunk. This is upper trunk. Okay. So the next block is supraclavicular block. We will see the screening later on in all the brachial plexus. So next block is supraclavicular block, and that, as we all know, that it is a trunk or division level block, and the scanning is almost same as interscalene, supine and lateral positions. The usual machine setting is also same, almost same. And when we put probe on supraclavicular region, just like this, directing toward the thoracic inlet, we will find this screen. See, first of all, you have to trace the anechoic pulsatile subclavian artery, which is resting on the hyperechoic first rib, which give you posteriorly acoustic shadow. And on bilaterally, you will find inferior to this hyperechoic rib, you will find pleura that gives posteriorly sliding side. So that is why that is how you can identify which is pleura and which is rib. So always make plexus on first rib. Okay. So the plexus over here will appear on posterolateral to the subclavian artery, and here also it will appear like hypoechoic nodule covered with hyperechoic rim, and that will give rise to a appearance of bunch of grapes. Here the inferior belly of omohyoid muscles, and the main importance of this muscle is that suprascapular nerve lies over here. So this can be an approach, that is the anterior approach of suprascapular nerve block. Okay, this is Ahmad Taha has invented this approach, studied rather we can say. So let's see some actual block in that the needle will, this is screening. So here we will find this is subclavian artery resting on this first rib, and we try to identify this area, that is a lower trunk which is formed by C8 and T1. See, again I am going on interscalene. This is C5, C6, C7, C8 ventral rami, and this is rib, and from here we will find 2 nodules that will form lower trunk. This is C8 and this is T1. In between the first rib and pleura. See, right? So this is lower trunk, this is middle trunk, and somewhere you will find the superior trunk. So this is pleura, rib, and this is bilateral. You will find inferior to this is pleura. So here the lower trunk identification is very important, and if you trace back, then you can really come to know that which trunk and division you need to block according to the surgery. I think all trunk and division we need to block, but depending on the type of surgery or your dermatome, you need to keep more attention to that particular area. Okay, let's see some actual block in that. Needle will come from lateral to medial, puncturing the skin, subcu and inferior belly of omohyoid, puncturing the cervical axillary fascia, and I am going toward the corner pocket area, not to spare the ulnar nerve, lower trunk specifically. I am injecting 15 ml of local anesthetic, and if the drug distribution is not proper, then I will again redirect toward the upper and medial trunk, and division. See, the 20 to 30 ml local anesthetic which I use in my practice, sometimes maybe more than that, but it's all depend on drug distribution. So if the drug distribution is satisfactory, I may reduce the volume. but the most of the time I use 30 mm. Let's see some clinical pulse. In that we can say make plexus always on first tip, not to puncture the pleura. Second thing is use corner pocket not to spare the ulnar nerves, that is lower trunk, and use color Doppler to identify the dorsal scapular artery and transverse cervical artery, because they are the normal artery over here, just like. And sometimes cervical ribs, which is present in 5% of population, can be a reason for your brachial plexus block, because trunk are divided with the presence of cervical ribs. You can see one of my video on YouTube regarding this cervical rib. This is dorsal scapular artery arising from the subclavian artery over here, and this is plexus. So you need to avoid these arteries while doing block. Hemidiaphragmatic palsy, which is reported on literature, is 50%, which is high, and most of the time, specifically for supracondylar fracture and all, you need to block intercostobrachial nerve, that origin from T2 intercostal nerve. So this area, which is spare, specifically in lateral position surgery, supracondylar, the patient will feel pain, and you need to block this separately. So I generally don't consider brachial plexus block as a spinal of anesthesia, spinal of upper limb, because it actually spares few things, and the upper limb is not covered by only brachial plexus. Some part of cervical plexus, that is supraclavicular nerves, and some part of this T2 is innervating the upper limb. So this is what I feel is, this is not a spinal of upper limb, brachial plexus block. So next topic is costoclavicular block. Second. So this is below clavicle block. And costoclavicular costoclavicular block is newer block, and that space is actually in between the clavicle and rib. Okay. And the main important target over here is a lateral, posterior and medial cord, and it is most proximal approach of infraclavicular block. So here we will find pec major, subclavius muscles, and here is the cord. This artery vessels are over here, clavicle over here, and this is one of the best good diagram to know the costoclavicular space. This space is compact, this space is fixed, it is having less variation, so it is very good space for brachial plexus block and can be utilized for continuous block. See, this is again costoclavicular space. In below clavicle block, the usual scanning is performed in supine position, and head, arms should be abducted in most of the time, and the probe is placed just inferior to the clavicle and medial to the coracoid process and parallel to the clavicle, and needling will approach from lateral to medial or from medial to lateral. See, when we put probe on costoclavicular region, first thing that you have to see is pec major muscle, subclavius muscle, and anechoid pulsatile subclavian artery and subclavian vein. Lateral to this axillary, or we can say subclavian artery, we will find the cords. Here the main peculiarity is that from here plexus look hyperechoic. Up to now above clavicle the plexus look hypoechoic, and from here the plexus appear more on hyperechoic. See, here identification of cord are generally not possible, and maybe it is more visualized when we inject a drug, and later on we will come whether the three cords are covered with local anesthetic or not. This is serratus anterior muscles, and this is intercostal, and this is pleura. So this is lateral approach, needle will come from here, and this is medial approach, needle will come from here, that is medial approach on the top of axillary artery. So let's see some actual block here. This is medial approach of costoclavicular block. In that we can say needle will come from medially to laterally, and this is pec major muscle, this is subclavius muscle, this is artery, subclavian artery, or we can say axillary artery, vessels, and this is costoclavicular space in which I am puncturing, I am going inside the sheath and injecting few drug to identify the cords. See, here we will find this is posterior cord and this is medial cord, lateral cord, and somewhere here we will find the medial cord. See, here when I am injecting, I found that these two cords are connected with each other, and one septum over here, and this medial cord is separated from these two cords. So again I am redirecting and targeting this medial cord. This is pleura and this is serratus anterior muscles. So here drug volume that I use is 20 ml of local anesthetic. Can be, you can go up to 30 ml, but 20 ml is good enough volume, and the researcher says that it gives rapid onset. Even I personally also feel that this is rapid, it gives rapid sensory and motor block, specifically in brachial plexus. Some clinical pulse, in that we can say the vessels are normally there, that is a thoracoacromial artery and cephalic vein. So see, this is artery vein, the cephalic vein entering over the subclavian vessels over here, vein, and some branches of thoracoacromial artery are arising from the subclavian artery. So vessels are normally there, just you have to avoid these vessels during your needling. Hemidiaphragmatic palsy is almost 0 to 5%. Few researchers says it is almost 0%, few have says 5. Still we need some more research to get the proper data. And here also we see, like in few cases we require intercostobrachial nerve depending on the type of surgery. So the next block is infraclavicular block. In that we will say, as we all know, it is a root level block, and this is lateral approach of infraclavicular block, in which the cords are targeted, they are lateral, medial and posterior. Scanning, in that we can say supine with arm abducted 90 degree with elbow flexion, and probe that I keep is approximately parasagittal, inferior to the clavicle and medial to the coracoid process. See, just like this. When we put probe on this, the usual machine setting, in that we can say we require a little bit more length, and needle length will be little bit high, and dose that I use is little bit high compared to supine costoclavicle. That I utilize is 25 to 35 ml of local anesthetic, and when we put probe over here, we will find anechoid pulsatile axillary artery, which is on anterior to it. We will find pec major and pec minor muscles, and cords are situated just in relation with axillary artery. See, means lateral cord is situated laterally to the axillary artery, medial cord is medially, and posterior cord is posteriorly. The needle will come from in between the clavicle and probe. See, just like here, in between the clavicle and probe, and from cephalate to caudal, and needle will come from here, and we will target the posterior cord. See, the same thing over here, and we need to deposit the drug in U-shaped manner. Like if the drug deposition is U-shape, then the block will be successful. High chances are there. See, this is PNS and USG guided infraclavicular, in that needle will come puncturing the pec major, pec minor, and reaching to the posterior cord, and we will inject nearly about 15 ml of local anesthetic and try to see the local anesthetic spread, that is U-shape. If it is not proper, then I will again redirect my needle to cover the lateral cord over here, and somewhere here needle I am withdrawing and targeting lateral cord. This is the needle, and this medial cord we need to block with a separate muscle puncture, not with separate skin puncture, and I will enter in this area, and again I inject 5 to 10 ml in medially. So 15 ml, this is 10 ml, and this is 10 ml, reasonably 5 to 10 ml. So likely 25 to 35 ml local anesthetic which I utilize in infraclavicular approach. So this is posterior cord injection, this is lateral cord, and this is medial cord. So this is pre-block scanning, and this is after block. See, the chords are little bit well visualized after drug injection. So this is peculiarity in that in this approach the chords are not well visualized every time. They are not identified rather every time, but after drug injection we will come to know. And position in most of the time in lateral approach we will find this. So let's see some clinical pulse. In that always use color Doppler to find out some vessels in the pathway of the needle. That is, see the thoracoacromial artery over here, which gives 5 branches over this area that come from this artery somewhere here. And see here the vein, cephalic vein entering toward the axillary vein, and somewhere here you will find the thoracoacromial artery branch coming from the axillary artery. So vessels are normally there, you have to avoid while doing scanning and while doing needling. Hemidiaphragmatic palsy is almost 0% or up to 5%. Few reports are there which shows the palsy is there. Again over here we require T2 block over here, and in this approach suprascapular nerve is mostly spared. So like you need traction for orthopedic surgery and you apply this block, then you require suprascapular nerve block, because that will create shoulder pain when they distract the fracture, right? So you have to use your block wisely depending on what, like a simple debridement, then it is okay, but if they want to distract the fracture and all, then the patient might have a shoulder pain. So use approach of that particular block wisely. So next block is axillary block. In that, as we all know, it is a individual nerve level block and 4 nerves are targeted. Same arm abducted, elbow flex, and transversely probe is placed in axilla, and the machine setting is almost same. When we put probe on axilla, we have to find out first anechoic pulsatile axillary artery, and most of the time the nerves are nearby to the axillary artery. See, first of all I scan for musculocutaneous nerve, which lies in between the this biceps and coracobrachialis muscles, and medial nerve lies on the top of the axillary artery, and radial nerve lies posterior to the axillary artery, and ulnar nerve lies mostly in between the axillary vein or axillary in between the vein and artery, that is 3 or to 5 o'clock positions. So let's see some screening. In that, this is musculocutaneous nerve. See, I'm just making trace back. This is biceps and this is coracobrachialis. This is axillary artery. Somewhere you will find the median, ulnar, and this is posteriorly to it is radial. See, this is conjoint tendon, which is very important landmark, because every our drug that should be deposited just superficial to the conjoint tendon. Okay. So this is 4x speed actually. See, I am targeting needle from cephalate to caudal and targeting the musculocutaneous nerve, and I will inject 5 to 7 ml of local anesthetic to block this needle, and then I will go to the posterior to the artery to block the radial nerve. After that I will go for medially, and this is somewhere you will find the ulnar nerve. So 5 to 7 ml for each nerve. So total volume is 20 or 25. It's all depend on drug distribution. So somewhere you will find the ulnar nerve. This is median nerve, and most of the time nerves visualize very well after drug injection. Specifically radial. And if you can visualize, this is a nerve which is median cutaneous nerve of forearm. This one. So after block I generally scan, and again I do trace back, and I found that each nerve is surrounded by local anesthetic in a well manner, and thereby we can assure the success rate. Let's see some clinical pulse. In that we can say don't use excessive pressure and frequent aspiration and slow injection, because vessels are normally there. veins maybe 2 or 3 and artery that is 1. Many times I have found 2 also. See, the hemidiaphragmatic palsy is almost 0% with axillary block, and again T2 block is required and suprascapular nerve block is required in some cases. So thank you. This is my presentation. And
just demonstrate intercostal brachial for sparing of this medial side.
okay, you want to demonstrate? Okay. That is, see, in private, I think most of the people, they utilize block in way of like they utilize 20 ml for supraclavicular block and 20 ml in axillary approach. So while you go for axillary scanning, you have to inject what I use is half dilution up to 5 to 10 ml, and I remain most of the time superficial to the deep fascia. So just on above to the axillary plexus, and I am going from cephalate to caudal and from artery to up to the down. If I'll get volunteer, then I will show you. We have a video also, but my laptop is not. So here, we change in general to resolution mode. High frequency linear probe is over here. It is okay, and depth is reasonably okay. Gain on depth that we can solve. Can we change this in resolution mode?
No,
there
this
any
is general mode actually.
here?
Okay.
So in brachial plexus, the depth is less, so I mostly utilize the resolution mode. First start with, you want to see first of all T2. So make ergonomic, because I many times have a backup pain and all. So how I utilize probe is that I keep probe marker over here on the same side, same way. This is probe marker, and somewhere here I found probe marker. So it based on my preference. Okay. So there is no thumb rule, I think. So we can reduce the depth. Make it or. Okay, Maharaj बताओ. अरे हाँ सर, अवश्य. Pointer क्या?
Pointer आवा.
So I most of the time before block I use scanning, and then I go for block and needling. Okay, so here we नीचे. Can we leg up please? आणि ऊंची थसे head up. Okay, relax it. Sonography check. Okay. See, I am trying for supraclavicular block. See, the artery, we need to block the artery. We need to see the artery round. And posterolateral to the artery, we will find the plexus. See here, middle scalene is visualized. Okay. So this is first rib, which gives first rib, which shows acoustic shadow, and this is pleura, in which we find sliding shadow. So when we give trace back, when I go with to interscalene area, see here in between rib and pleura, we'll find C8 and T1, they are coming out. Can you see it? One round structure over here,
Don't
not
worry,
that
if you don't
clearly.
see, you will see on the station, because sometimes on the screen it is difficult to show.
In every patient, it might not be possible to visualize these things, but in between this pleura and rib, the C8 and T1, they emerge and they form lower trunk. And when we go upward, see, this is dorsal scapular artery, which I have shown with color Doppler. Can you visualize?
Pulsatile structure.
That is normal artery present over here when we scan from supraclavicular region to the interscalene. Like, and it is very big artery that branch from subclavian artery. See, color is visualized only when the probe and artery is at 90 degrees. So you just see the pulsator. Okay. So when we go upward, this is dorsal scapular artery. See here, you can visualize the plexus, and one more thing is this is posterior tubercle of C7 vertebrae, and thereby this is lower trunk, thereby it is C7 root. This is posterior tubercle. When we go upward, we will find, I think this is C7, okay, and posterior tubercle is found over here, anterior tubercle is absent, so that we can visualize the vertebral vessels.
Can you appreciate vertebral vessel?
See, you can see some pulsatile structure.
દેખાય છે? Yeah.
Okay, so this is C7 root because of the presence of vertebral vessels. When we go upward, the C6 will appear over here, and it is having two tubercle, anterior and posterior tubercle. Like, okay, this is C6. And this is C5. Again, it is having two tubercle, and so this is C5. So this is C5, C6, dorsal scapular artery, and C7. So I generally utilize probe like this, and I will enter from lateral to medial and target C5 and C6 root. Let's see superior trunk, how superior trunk is formed. So this is C5 and C6, which will join later on, and they form superior trunk. And if I go caudally, then this superior trunk will give an origin of SPA, that is suprascapular nerve, which lies mostly on the lateral part and anterior and posterior division. Not very well visualized over here. Again,
Can anyone tell which nerve lie in the substance of middle scalene muscle? Anyone? Anything else? Another nerve? Root level એ કઈ નવ આવે? Root and trunk level. Brachial plexus ની branches. Long thoracic nerve. Right?
so
કેટલા
while puncturing middle scalene, you have to take care of these nerves and vessels, both. So here the middle scalene is muscle motor, plexus is small, and we are not getting that much resolution. See, here the branch will coming out from the axillary artery. Rib ni upar. transverse cervical artery is visualized in when we form the superior trunk on the top of. Can you see some pulsation in superficial transverse? So that is a superficial cervical artery, which is in between this plexus and this cervical plexus. Means brachial in between these two things, about to the deep fascia. So you have to take care of these things while doing interscalene block. Okay. When you go for supraclavicular block, you have to place the plexus on first rib, not like this. Okay, always make plexus on first rib, not to puncture the pleura. So the rib will act as a guide and it will not allow to go much deeper. Okay, and needle tip visualize all the time. So bilaterally, see, we can visualize the lung sliding side. So the lung is moving, the tissue is moving like this, so that is sliding side, and the hyperechoic rib is showing posteriorly acoustic shadow. So thereby you have to identify the rib and pleura. Then I will go with costoclavicular.
By the time scan, why we inject in the corner pocket? Question to all of you. Anyone?
Ulnar nerve, or it's a
Ulnar
it's a lower nerve.
lower trunk, right? To prevent. And what is traffic light appearance? C5, C6, C6. Very good. It is not C7, right?
So above clavicle, patient is supine and arm is just like this. Okay, arm is straight. Below clavicle, the arm is abducted and elbow is flexed at the 90, both at 90 degrees. Okay, not too much. It is on both at 90 degrees. And I will try to show the costoclavicular. See, this is from supraclavicular fossa and going into the costoclavicular space. See, this is supraclavicular. Okay.
You can see here as well. Picture is better in this.
Better in that. And when I go downward, this is clavicle and this is costoclavicular space. We are entering over the costoclavicular space and try to direct my probe towards the cephalad. Okay, this is a subclavian artery over here, and somewhere you will find this vein, subclavian vein, in where the cephalic vein is entering over. Can you see?
Yeah, you can see it now.
Okay, just only my probe pressure, it is compensated. And few arteries, branches from subclavian can be visualized. Let's try to see. On that part, on laterally also, I think.
This one.
Round structure. So it gives branch over here in
this one. Right, so some branch here also.
So here thoracoacromial artery gives 5 branches. So this is vascular area, and you need to spare these arteries. You need to take care. Now lateral to medial approach, in that I have to stand over here, like sit over here, and needle will come from cephalad to caudal like this. Needle will come over here and I will enter the costoclavicular space, just like this, not keeping away the axillary cephalic vein and all the structure. So directing towards the head end. And you can visualize the costoclavicular space, and I will enter from head end to lower end, means cephalic to caudal. For medial approach, I will stand on the opposite side and I will enter the needle from medial to lateral. Okay? Which one is better, that I don't know. Initially I started with this approach and end with medial approach. So I am not I can't say which is better. It depends on where the machine is going. Okay? So this is costoclavicular. When you go for infraclavicular, the probe has to be put parasagittally inferior to the clavicle, and see, the plexus is coming out in this way. So you have to be almost at 90 degrees to the plexus. Then you can visualize better plexus. So this is lateral infraclavicular block. The axillary artery and axillary vein over here, above to it is pec minor and pec major, and the roots are over here, cords are over here, and here also you find the branches of thoracoaquina. Can you see some pulsation on the just this part? Okay, so you need to be careful while injecting the drug. See here, the artery gives posteriorly apostolic shadow, and thereby this may not be a posterior cord. So you have to see it while you inject the drug. Okay, and many times it is not visualized very well, and when you inject the drug, at that time you will come to know that this might be a posterior cord, or it may be present over at 3 or 5 o'clock position in relation to the axillary artery. See here, the vein, cephalic vein entering toward the I'm not getting that proper. Okay, from needle here come in between the clavicle and probe from here, and I will reach at the level of 6 o'clock position to the artery and inject drug for posterior cord, and I will look for U-shaped drug distribution. If distribution is not proper, then I will again redirect needle to 3 o'clock position and 9 o'clock. Okay, so 15 ml in posterior cord, 5 to 10 ml in medial and lateral cord, so total volume is 25 to 35. Now I am going for axillary. See, there are 16% variation in musculocutaneous. But most of the time very fortunate that I found all the time muscular. See, I don't go much in axilla. I just go little bit on arm area and first try to see the musculocutaneous. Now it lies in between the biceps and coracobrachial. And when I trace, it will divide into anterior and posterior division later. And when I go back, it will reach near to the axillary artery. So here we are not getting that, but this is musculocutaneous. Okay, this is lateral. So I start with first targeting this musculocutaneous nerve block, then I go towards the from same skin puncture I reach for radial nerve over here. See, this is conjoint tendon, which gives you a landmark that you do not have to pierce this conjoint tendon. The drug deposition should be superficial to the conjoint tendon, and this is radial nerve, somewhere here. When we trace radial nerve distally, it will go into the spiral. Sorry, I am not stable with scanning. So it will fall down and reach to the radial groove of humerus bone. Okay, not properly getting, but this is white structure is actually radial now. Okay, we'll go for median now then on the top of axillary artery, and this artery is this now median now lies almost on the same nearer to this axillary artery. See, I am tracing toward the elbow. Median nerve lies on the top of at 11 or 12 o'clock positions. When we go toward the elbow, this median nerve lies laterally, and it will flip toward the medial. See here, up to now relation is supralateral median nerve. When we reach to the elbow, it will flip and it will become on medial part. See, okay, so this is medial, flip and become lateral to the axillary artery. So we can scan up to the elbow to found that this is median nerve. This is how we need to actually identify which nerve is there or which nerve is what. What is this nerve? Means traceback is always helpful over here. Look at 1 o'clock position, in that you will find ulnar nerve. When we go distally, on the top of this is ulnar. When I go distally, it will leave the area of axillary artery here, okay, and it will enter nearer to the median epicondyle. Can you see? This is so this is median epicondyle, now reaching up to the medial epicondyle, this one. Okay, so this is ulnar nerve. In that way you can verify that this is ulnar nerve. On the top of this one, and it is at 1 o'clock position with the artery. And this is conjoint tendon, and somewhere you find the radial. Radial goes on lower part and medial. This one. Okay. If you can't visualize radial, you can trace over here in this elbow level. That is, here you will find radial. Can you see this spot? This is radial now at elbow level. Right? This is median now. Median now, and somewhere you will find the ulnar. This. still on the deep. Okay, that is not in my practice. So below elbow, I don't go for any nerve because they are just analgesic. Okay.
Any questions?
Very good. Thank you for in-depth explanation. Any question or any?
See, I decide based on my convenience. But if we say it depends on surgical type, like if the block is like lower humerus or like above to the elbow, then I will go with supra or interscalene, mostly supra. If the block is below the elbow, then if the surgery is below the elbow, then I utilize axillary or costoclavicular or infraclavicular. But in my usual practice, I utilize costo, supra, interscalene. Axillary, I
think he's asking about choice between supra and costoclavicular, right? Yeah.
Both are covering the same things. In between these two approach, there is nothing now is there which is not blocked. Means both are almost same. Just if you want to spare the phrenic, then utilize costoclavicular. But see, what I say is phrenic is consequence. So opposite lung should be good enough to cope up phrenic palsy. If you want to avoid phrenic palsy, then use below clavicle block, specifically axillary, which is having almost nil phrenic nerve palsy. Little bit high when you approach for infraclavicular and little bit high when you approach for shoulder arthroscope. In that I utilize interscalene or superior trap. In few cases I have utilized costoclavicular block also, just to check whether the costo can be utilized for shoulder surgery or not, along with supraclavicular.
Regarding costoclavicular versus supraclavicular, literature says that incidence of pneumothorax is also lower with costoclavicular. And another advantage is you can put catheter. This is a muscular area, so catheter retention will be better with costoclavicular as compared to supraclavicular. So these are two advantages other than phrenic nerve palsy for costoclavicular, and that's why it is becoming more and more popular. Otherwise, it is like blocking the supraclavicular area from the below. It is same as Siddharth told. It is more or less same. Effect is similar. Only thing left is suprascapular nerve, which is spared when you give costoclavicular block. So when you want to use it for shoulder surgery, you have to give costoclavicular block, and suprascapular nerve you again require 3 to 4 ml of
See, in my practice, I have seen that when I go for costoclavicular block, actually I found that later on, when the surgery, like half an hour after the block, I found that patient can't do this. So in my practice, actually, I found that suprascapular nerve is blocked with costoclavicular.
Yeah, if volume is good, drug will of course spread cranially.
But in the classical parasagittal or lateral infraclavicular block, suprascapular is always spared, all time. But in costo, when I ask patient to do this, he can't. When I ask patient to abduct, he can't. With volume of 20 to 30. I generally utilize little bit more volume of costo because to get a early onset. See, and this one thing is also there in my practice that when I utilize costo, I get rapid onset. When I finish the series, patient will say that it is numb. So rapid onset is also with costo, but with little bit higher, that is 25 or like 20 to 30 ml.
Basically some difference why he is getting faster onset. When we give supraclavicular, if you've seen video by Dr. Siddharth, we try to remain outside the plexus. We don't go inside the plexus. So it is extra plexus block to avoid the nerve injury. That's why onset is little bit slower. There are people who recommend intraplexus injection also, like pierce the sheath and inject the drug inside the plexus. But chances of nerve injury are there. So if you inject the drug extra plexus, onset will be slower. While at costoclavicular level, you are at the cord level, and you are injecting the drug very close to the cords, and that's why you are getting the onset faster, right?
Because connective tissue are little bit less compared to supraclavicular, costoclavicular. And generally, see, people say it's like 2 injection technique, single injection technique, but I don't utilize that. I just see whether the cords are covered or not.
Yeah.
So here the few papers are that which shows that there is a septum in between that, and medial and posterior are mostly they are all together, and the lateral is isolated. In my video, you have seen that the lateral and posterior are along with one sheet, and medial is separated. So these anatomical variation are there. So what you need to see is whether all cords are covered with local anesthetic or not. If they are covered, then leave the septum wherever it is. Our target is to cover the every cords. So if we can cover those cords, then definitely we will not get any block problem.
Thank you, sir.